the potassium-sparing diuretics, we have the aldosterone antagonist and we have the sodium channel blockers. Let's start with the aldosterone antagonist. Now, we know that the aldosterone is produced from the adrenal cortex, right? And it is a steroid, so it has an intracellular receptor, right? Now we know that the main function of the aldosterone is going to be in the distal part of the distal convoluted tubule as well as the collecting duct. So there in the intracellular area there is going to be a receptor for the aldosterone. When the aldosterone binds to it, this is going to enhance the excretion of the sodium channels on the apical side of the principal cells, and it is going to enhance the excretion of the sodium-potassium ATPase on the basolateral membrane of the principal cells, meaning that we're going to increase the sodium and the water retention at that area, which is the distal convoluted tubule as well as the collecting duct, right? And well, here we have two drugs, the spironolactone and we have the epilerinon. These guys are a little bit different since the spironolactone is not selective. It blocks any mineralocorticoid receptor. We have three types of mineralocorticoid receptors. One of them is the aldosterone receptor, the other one is the progesterone receptor, and the third one is the androgen receptor. So when you give a spironolactone, actually it is going to block all of them. It doesn't choose one to block it, but it is going to block all of them. Now, the epilerinon, on the other hand, it is specific for aldosterone receptor blockage only. Now, something I forgot to mention is basically that the aldosterone is going to enhance the excretion of both the potassium and the protons, right? So the potassium and the proton loss is going to increase when the aldosterone level increases. Now, another difference between the spironolactone and the epilerinon is that the spironolactone is not an active drug. It is a prodrug that needs to be converted to the active drug, which is the so-called decanrenin. Now, decanrenin is actually produced in the liver by biotransformation from the spironolactone. On the other hand, the epilerinon is active already. It doesn't need to be converted to the active form. The oral bioavailability of the spironolactone is 70%, same for the epilerinon, but it has a little bit higher plasma protein binding than that of the epilerinon. Now, let's come to the uses. So, when we block the aldosterone receptor, the intracellular receptor, by the spironolactone or the epilerinon, we're going to decrease the sodium and water retention, right? And then we're going to decrease the elimination of the potassium and the protons, meaning that the potassium and the protons are going to be building up in our bodies, okay? So there is going to be a hyperkalemia and metabolic acidosis in both of them, in the epilerinon and the spironolactone, since both of them are blocking the aldosterone receptor. Now, how do we use these drugs? We use the spironolactone always in combination. Same for the epilerinon. In combination with what? With thiazide. We know that the thiazide is potassium-losing diuretics. Now, why do we use it with thiazide? Because if we use the spironolactone alone, there is going to be a hyperkalemia, right? And it is really hard to monitor the hyperkalemia all the time, and like what can we do if there is a hyperkalemia? How can we reduce the hyperkalemia? So what we do is basically we give the thiazide together with the spironolactone in order to keep the potassium level at a neutral physiological concentration, right? Now, the uses or the indications of the spironolactone, the first and the main thing is the hyperaldosteronism. We know that the hyperaldosteronism is basically an excessive production of the aldosterone, can happen primarily when there is an adrenal cortex hyperplasia or when there is an adenoma. It is like the Conn's syndrome, you know, the Conn's syndrome, right? No, the Conn's syndrome and the hyperplasia. So these are the primary hyperaldosteronism. The secondary hyperaldosteronism happens due to the increase in the RAS system. Increase in the RAS system function. And we said that the RAS system can be highly activated due to the cardiac failure. So if there is a cardiac failure, there is going to be a prolonged activation of the RAS system, which means that there is going to be prolonged excessive production of the aldosterone as well. This is going to lead to secondary hyperaldosteronism. On the other hand, if there was ascites, for example, so someone has like a hepatic cirrhosis or hepatic failure, they are going to develop ascites, and ascites is basically this edema that is going to lead to loss of so much of the volume of the blood into the abdomen area, right? And this means that there is going to be a hypotension. This hypotension is going to activate the RAS system. The RAS system is going to lead to hyperaldosteronism. So when there is hyperaldosteronism, we can just give the spironolactone in combination with the thiazide and control the aldosterone receptor. We block the aldosterone receptor, we inhibit this excessive amount of the aldosterone from functioning, and we keep the potassium level at a neutral level. Okay, now Hirschsprung in females. Hirschsprung is like hairy, basically. Hairy females. Why? Because we said that the spironolactone is going to block the androgen receptor. We know that the androgen receptor is the guy's hormone. Now it is the guy's hormone. If we block this receptor in females, we're going to actually decrease the growth of the hairs. So in a hairy female, we can actually give the spironolactone to solve this problem. On the other hand, we use the eplerenone in combination with the thiazide as well, but we use it for hypertension, the chronic form, and the chronic heart failure and myocardial infarction. Now, so we said that both of these guys, as a side effect of them, can develop hyperkalemia because the aldosterone used to eliminate the potassium. Now we don't have elimination of the potassium. It is going to build up in our body and cause hyperkalemia on the other hand. And same goes for the protons. They are going to accumulate in our body and cause metabolic acidosis. But in spironolactone, because they are not specific, they are going to lead to steroid effects. The steroid effect is basically because it is blocking the androgen and the progesterone receptor. Now, we have a male patient who's receiving spironolactone. His androgens are not able to function anymore because we have blocked the receptors. What is going to develop? He's going to develop a bigger breast, basically. This is the so-called gynecomastia. Okay? So this happens in males. On the other hand, in females, a menstrual dysfunction can develop, right? So basically, if they are receiving spironolactone, they may not have a period. So amenorrhea can develop, okay? And then when they stop the drug, I think after 2 months, the period is going to come again. Okay, another, well, let's forget about this, okay? So that's it for the aldosterone antagonist. Let's move to the sodium channel blockers. So our second potassium sparing diuretics is going to be the sodium channel blockers. Now we have here two drugs, the amiloride and the triamterene. Now, something special about them that they reach the site of action through the organic cation transporter 2, OCT2, from the basolateral membrane of the proximal convoluted tubule, and then in the apical membrane they are gonna get into the lumen through the MATE transporter, the MATE, to the lumen. Then they are gonna travel through the nephron to reach the collecting duct. In the collecting duct, they are gonna block the sodium channels, the epithelial sodium channels that are present on the apical membrane of the epithelial cells of the collecting duct. Okay, by blocking these guys, okay, the sodium is gonna accumulate in the collecting duct, meaning that there is no lumen negative transepithelial potential like the previous ones, potassium losing diuretics that we spoke about, which means that there is no need for actually losing potassium and protons to neutralize any negativity in the lumen, because there is no negativity developing in the lumen anyway. Okay, the side effects of these drugs, that they can lead to hyperkalemia and metabolic acidosis because we can't lose the potassium and the protons, and there is an interaction with the ACE inhibitors and the angiotensin receptor blockers. And this is because, as we mentioned in the previous video, that these guys also are causing hyperkalemia. So, sodium channel blockers and aldosterone antagonists both have interactions with the ACE inhibitors and the angiotensin receptor blockers because of the hyperkalemia. Now, the other thing that the amiloride and the triamterene can lead to GI symptoms like vomiting, nausea, abdominal discomfort. Now, what's worth mentioning as well is that triamterene is not a prodrug. It needs hydroxylation as well as sulfation in order to form the active form. Now, the sulfated form of the triamterene is water insoluble, so it doesn't have any water solubility, which is going to make it accumulate in the kidney. When it accumulates in the kidney, it is going to lead to interstitial nephritis. This is going to lead to crystalluria. Interstitial nephritis because of the accumulating sulfated form of the triamterene, which is the active form, leading to crystalluria. Also, the triamterene is going to block the folic acid. It is a folic acid antagonist, leading to megaloblastic anemia on the long run use. Now, the triamterene, if it was exposed to a UV light, it is going to form an allergen, and this allergen is going to lead to photosensitization. So these three side effects are specific for the triamterene, and they don't really happen if you're using the amiloride. Now, the indications of these drugs as a diuretic, they can be used in combination with the thiazides. The second one is the cystic fibrosis. If we were using the amiloride for cystic fibrosis, we would use it as an inhalative form, and basically when it gets inside, it is going to block the sodium channels that are present in the epithelia of the bronchi, and the sodium is going to accumulate in the mucus of the bronchi, and this means that the water is going to accumulate in the mucus as well. So if the water content of the mucus is increasing, then the mucus thickness is going to decrease, right? It is going to become less viscous, and this is going to make the mucociliary movement, better. The mucociliary movement is going to become better, and like they can basically cough out the mucus. So we can help the cystic fibrosis patients by an inhalated form of the amiloride. The other indication is the lithium intoxication, because these drugs are going to also inhibit the lithium absorption. Now, the carbonic anhydrase inhibitors. So we mentioned before that the sodium and the bicarbonate are going to reach the proximal convoluted tubule after the filtration, right? And we said since they have charges, they can't pass through the membrane because they are lipophobic. They need a transporter. We said that there is a transporter for the sodium, but there is no transporter for the bicarbonate. So the bicarbonate is going to meet the proton and form the carbonic acid, which is going to dissociate by the function of the carbonic anhydrase enzyme into the water and the carbon dioxide. Water and carbon dioxide are going to diffuse through the membrane into the intracellular area, and then they are going to combine back to the carbonic anhydrase, which is going to dissociate into the bicarbonate and the proton. And this process is also happening by the carbonic anhydrase. Now, after that, the proton is going to be pumped back into the urine through the proton-sodium exchanger, while the bicarbonate is going to be absorbed along with the sodium by the bicarbonate sodium symporter to the blood. Okay, let's say that we have applied the carbonic anhydrase inhibitor to a patient. So this process is going to be inhibited, which means that the bicarbonate is not going to be absorbed, and it is going to form sodium bicarbonate, and it is going to be eliminated in the urine. Since these guys are osmotically active, they are going to basically drive the water loss in the urine as well, right? So they are primarily salicylic, loss of the salts first, and then secondarily diuretics. Then the loss of the water is going to happen. And the carbonic anhydrase, like the loop diuretics and the thiazide diuretics, it is going to reach the proximal convoluted tubule through the OAT, the organic anion transporter 1 and 4. Okay, now here we have the acetazolamide, the methazolamide, the brenzolamide, and the dichlorophenamide. Okay, so what is the net result of applying the carbonic anhydrase inhibitors? We said that there is going to be loss of the sodium and the bicarbonate and a consequent loss of the water, and there is going to be proton retention because we're not going to be eliminating any protons through this process, right? Because the carbonic anhydrase net result was basically increasing the absorption of the sodium and the bicarbonate and consequently the water and the loss of the protons, right? Now when we apply these drugs, the opposite is going to happen. Sodium bicarbonate loss, water loss, but proton retention. Okay, these guys are considered very weak diuretics. This is important. Why are they considered very weak diuretics? Because if we think about it, now we applied the drug, right? And we have inhibited this process. Okay? Now, the bicarbonate that has reached the lumen of the nephron by the filtration is going to be lost from our body. It is never going to be reabsorbed. Okay? Now, so the next bicarbonate is going to face the same thing. It is going to reach the nephron. It is going to be lost forever. But this means that basically we're going to be running out of all the bicarbonates. So for the next day, for example, we're not going to have any bicarbonate reaching our nephron, which means that the carbonic anhydrase inhibitors wouldn't have any function actually. And that's why they are very weak diuretics. Okay, now in the eye, there is also a carbonic anhydrase present there, responsible for the formation of the bicarbonate to drive the carbonic acid, to drive the water, to form the aqueous humor. If we apply carbonic anhydrase inhibitor, there is going to be decrease in the aqueous humor production in the eye as well, which is going to decrease the intraoptical pressure that can help the patient with glaucoma. Now, we know that in the red blood cells, as you studied in physiology, that it actually has different forms of transporting the carbon dioxide. And one of them was using the carbonic anhydrase, right? And if we inhibit the carbonic anhydrase in the red blood cells, this means that the red blood cells are no longer able to carry the carbon dioxide away from the tissues towards the lung to be eliminated from the body. And this means that the carbon dioxide is accumulating in the tissues, more importantly, the brain. So, if the carbon dioxide is accumulating in the brain, what is going to happen is somnolence. Somnolence is basically sleepiness, and paresthesia in addition to anti-epileptic effect. Now, so as a side effect of the carbonic anhydrase inhibitors, the patient may be sleepy and paresthesia may be experienced. On the other hand, the calcium phosphate stones can develop in the urinary tract. Why? This is because the carbonic anhydrase inhibitors, they may lead to the increase in the elimination of the phosphates as well as the ionization of the phosphates. So the phosphates in the urinary tract are going to be more prone of the formation of the calcium phosphates because they are ionized, and these can accumulate and form stones in the urinary tract. Now, so when we talked about actually the function of the carbonic anhydrase inhibitor, we ended up saying that the sodium bicarbonate is going to accumulate in the urine. Now, if the sodium bicarbonate is accumulating in the urine, this means that the urine pH now is more basic, right? It is an alkalic urine. So the interaction is going to be here because the alkalic urine developing is going to increase the reabsorption of the basic drugs. Now we know that if the drug is basic and the urine is basic, there is not going to be any ionization of the drug, so it can be reabsorbed, right? It is continuously reabsorbed, and this means that its elimination is going to be prolonged. On the other hand, if another drug was administered and the urine is alkalic, and the drug is acidic, so the drug is going to be ionized because the pH of the environment is the opposite. And if it is ionized, this means that the reabsorption in the nephron is going to be decreased. And that's why the carbonic anhydrase inhibitors, they have interaction with the amphetamine, which is a basic drug. Because whenever the body is trying to eliminate the amphetamine by the kidney, it is going to be reabsorbed again. Because the urine is alkalic and the amphetamine is basic. There is no ionization of the amphetamine is going on, and the continuous reabsorption is happening, and the elimination is going to be prolonged. On the other hand, if we administer aspirin to a patient who's taking carbonic anhydrase inhibitor, the aspirin is going to be eliminated right away, because as soon as it reaches the nephron, it is going to be ionized, because aspirin is acidic and the urine is alkalic due to the sodium bicarbonate. So its elimination is going to be fast, and it may not function as needed. Now, what are the indications of the carbonic anhydrase inhibitors? We said it is a very weak diuretic, so I don't think that it is used as a diuretic anymore, but it may help with the glaucoma. Actually, in case of a glaucoma, we don't use the drug systemically. Why would give someone carbonic anhydrase orally or whatever systemically? We would just give it topically, right? And in this case, we would use the brinzolamide. The brinzolamide is used in case of the glaucoma. We may use it against the epilepsy and for the altitude sickness. Okay, now, so in high altitude, what happens is basically the air pressure is lower, right? And this means that the atmospheric pressure is lower than the pressure in your lungs. So whenever you are doing expiration, the carbon dioxide is going to leave really fast, right? Because you know the carbon dioxide leaves from the higher pressure to the lower pressure, right? Now, if this pressure difference is huge, like at high altitudes, where the atmospheric pressure is very low, the carbon dioxide is going to leave your body really fast. And if the carbon dioxide leaves really fast, this means a respiratory alkalosis is going to develop, right? Because the carbon dioxide has left. So we may give a carbonic anhydrase inhibitors to a patient who is living in altitude sickness temporarily. He's not adapted to this environment, so he can just avoid the altitude sickness. Okay, let's move to the osmotic diuretics. Diuretics is the osmotic diuretics. As we mentioned at the beginning, that the osmotic diuretics are the only diuretics that are basically primarily diuretics and then secondarily saluretics. Let's see how this work. So the osmotic diuretics like the mannitol, the urea, the glycine and the isosorbate, when they are in the blood, basically they are osmotically active, which means that they are going to drive the water towards them. So the water that is present in the extracellular space, for example, in the extracellular space and also from the intracellular area, it is going to be driven towards the circulation when the osmotic diuretics are circulating in the blood. This is going to increase the volume of the blood, and this is going to increase the perfusion of the kidney. Now, so when the perfusion of the whole kidney is increased, this means that the glomerular filtration rate at each nephron is going to be increased, right? Now, so the osmotic diuretics now are in the nephron, and there is a huge volume reaching the nephron as well, which means that the flow through the nephron is going to be really fast because the volume of the water is really high, right? Now, and because these osmotically active diuretics are in the nephron, they are going to also inhibit the water absorption from the nephron. So the water is going to be inside the nephron, not even being able to leave it. So it is going to flow really fast along the nephron with a huge volume. This is going to lead to gradual washing out of the corticomedullary gradient. Now, how does this work? We know that basically here there should be the potassium-sodium chloride reabsorption, right? And it was responsible for building up the osmotic gradient around the loop of Henle. Now, when the volume is really high and the flow is really fast, there is no time for that. We can't really do this active transport because the flow is really fast, right? so there is no time for the reabsorption, and the water is not gonna it is not gonna be reabsorbed from the passively from the descending loop of Henle, because we have more osmotically active inside the loop inside the loop of Henle, right? So it is gonna keep the water with it inside the nephron, and then we're gonna have excessive urination. So due to that, it is primarily diuretics and then secondarily saluretics. So first we lost the volume, and due to that, due to the huge volume loss and the very fast flow through the nephron, we're losing the salts as well. Okay, now the indications for the osmotic diuretics is in case of the acute renal failure with oliguria. The very important thing is we give these drugs to avoid developing the anuria, okay? So if the patient developed anuria, we should stop the osmotic diuretics, okay? Why would that? Why should we stop the osmotic diuretics if the patient developed anuria? Because as we said, that the osmotic diuretics are going to increase the volume in the circulation. And if there is anuria, this means that the volume is increasing in the circulation and there is no urination. So this is going to add much more work on the heart, and it can be really harmful. On the other hand, it can be used to decrease the intracranial pressure and the intraoptical pressure. So, because these osmotic diuretics are not going to only go to the kidney, but they are going to circulate through our body and reach the brain, so they can drive the water towards the circulation from the extracellular space and the intercellular area, as well as from the intracellular spaces. So we can decrease the pressure in the intracranium. And it is going to decrease the intraoptical pressure as well. So we may use these drugs for pre-operation and post-operation of the brain and of the eye. Now, the other use is the so-called dialysis disequilibrium syndrome. This syndrome develops when the patient goes for hemodialysis, but this hemodialysis was so aggressive that he lost the ions in his, from his serum as well. Now, if the patient loses the ions from the serum, this means that the osmotic pressure of the serum is decreasing so much, so the water is going to move to the cells. And this is going to lead to a brain edema, right? So let's think about it again. The patient went for hemodialysis, right? But the dialysis was really aggressive. He lost the ions. The osmotic pressure of the plasma has decreased. The water is going to move to the higher osmotic pressure, which is inside the cells. This is going to lead to swelling of the cells, which means that it can lead to an intracranial edema, or we call it the cerebral edema. Now, we can give the osmotic diuretics in this case in order to move the water back to the circulation and decrease the edema. Now, the fourth use is the cystic fibrosis. So basically, it is almost the same. It is going to keep the water in the mucus, in the bronchi, and this is going to make it less viscous and we can cough it out easier. Now, the side effect of the osmotic diuretics is an increase in the overload on the heart, because there is going to be so much volume in the circulation, so the heart might not be able to cope up with all of this volume, right? And the pulmonary edema can develop on one hand, and if the patient has already a pulmonary edema, then it is contraindication. We can't give a patient osmotic diuresis and increase the volume in the circulation when the patient already has a pulmonary edema or when the patient already has a weak heart, because this is going to be like an extra work that the patient wasn't even able to deal with the normal volume. Okay, so the other contraindication is going to be the anuria. So as I mentioned, because there is going to be an increase in the volume of the circulation, but there is going to be no urination. So the heart is going to be in continuous stress. And the intracerebral bleeding. So we can't give it for the intracerebral bleeding, but if it was just an edema, then we can give the osmotic diuretics, or we can give it pre-operation or post-operation of the brain. I think that's it about the diuretics. Thank you so much for watching. I hope it was helpful for you. Yeah, I know it is a very long topic, but yeah, what can we do? So yeah, if you have any questions, you can contact us on our Facebook page. See you in the next.